morning, everyone, and welcome to our kickoff for the 2019-2020 Grand Round Series. I'm Ann Vanderstoop, and Carol Rockhill and Maria Felenchak and I are the Child and Adolescent Psychiatry Grand Rounds Committee. And I'm thrilled to introduce today's speaker, Dr. Maggie Sibley, who is a clinical psychologist and associate professor in our University of Washington Department of Psychiatry and Behavioral Sciences. Over the past decade, I have followed Dr. Sibley's work. She first came on my radar in, I think, 2014 when she became a member of the International Society for Research in Child and Adolescent Psychopathology. And I think it was 2015, we were preparing for that meeting in Portland, and Joel Nigg was president, and Joan Luby was the incoming president, and the three of us were here at University of Washington reviewing all of the symposium applications. And symposium at ISERCAP is an hour and a half where you propose a talk, or a topic, and then you get 3 speakers to speak to that topic and a discussant. And out of the 22 that we reviewed, Maggie had submitted 3. Yesterday, and so you all, I'm guessing many of you met Maggie in January of 2018 when Jim Swanson came and gave a talk about long-term follow-up from the MTA study. My recollection about that talk was that Maggie was well represented, and so yesterday I went back and watched it. And sure enough, Dr. Swanson featured Maggie's 2017 work on the persistence of ADHD diagnosis over the 16 years since the start of MTA. And then he featured a 2018 paper that she'd published in the American Journal of Psychiatry on adult onset ADHD. Over the course of his talk, Jim Swanson described Maggie variously as a new leader, a terrific investigator, and finally publishing the best papers in the MTA group. And 3 times at the beginning and middle and end of the talk, pictures of Maggie popped up onto the screen, and they weren't even the same picture. And next thing I knew, Maggie was considering coming to the University of Washington. I was stunned and very excited. Brilliant, open-minded, compassionate, passionate, creative leader in ADHD research was considering leaving her tenured position at the ADHD capital of the world, Florida International University, to make her research home in the Seattle Children's Research Institute. Wow. And she did it. So Maggie's most recent contributions reflect a synthesis of what she's learned about ADHD that persists into adolescence, what she's learned about parent-child conflict in ADHD, about brain function in adolescents with ADHD, and an investment of this knowledge into developing and testing new treatment models. Some of her most recent papers, a pilot trial of supporting teens' academic needs daily, a parent-adolescent collaborative intervention for ADHD, a school consultative intervention for adolescents with ADHD, effectiveness of motivational interviewing, enhanced behavior therapy for adolescents with ADHD, a peer-delivered intervention for high school students with ADHD. Welcome, Maggie. We're really happy that you've joined our faculty and are excited to hear you talk about treatment for building executive function skills and motivation in teens with ADHD.
Good morning, everyone. And that was a really nice introduction, Anne, so thank you so much. I'm really happy to be here. What I was saying before the talk is that I just learn about a new person every day that's here that I am so excited to eventually get to meet and talk to. So a lot of you, I'm sure, are in this room, and I look forward to meeting all of you. So just some disclosures real quick before I get started, I think most relevant to this talk is that I received book royalties for a treatment I'm going to describe. So, ADHD. We now know that ADHD is a lifespan disorder, right? So, we can detect it in as early as young children. We certainly are very familiar with the fact that it manifests in elementary school age children. And over the last 20 years, there's been increasing recognition that ADHD persists into adolescence, young adulthood, and even into the full lifespan for at least a subset of people with the disorder. And that it has a genetic link, so that a lot of times when you're working with families, more than one person has ADHD in the family. And when we think about a teenager with ADHD, the longitudinal research literature suggests to us that about 50% of them will continue to meet criteria for the disorder through adulthood. And so I think as clinicians who are treating teenagers with ADHD, one of our main goals is to see what we can do to move more and more kids from the category that persist into the category that desist. And so our goal is long-term to try to change the trajectory of illness for these kids so that they end up in that kind of remitted group by the time that they're adults. But I think a big puzzle in the field has been, how do we do that? This is a particularly challenging group to work with clinically. And so as a researcher, my first piece of this puzzle in trying to figure out what we can do is to look at the literature and the longitudinal research that we've already done on adult persistence of ADHD and try to see if there's any clues as to predictors that might help us identify targets for intervention to change that long-term trajectory. So in a lit review that my colleagues and I did about, 4 years ago, we went through and we looked at the different predictors of persistence, and there's not much out there, to be honest. But some of the clues that we got were that childhood ADHD severity, number of comorbidities that a person has in childhood, parental mental health problems, and negative life events in adolescence were some of the key pieces to that puzzle that would determine whether or not someone had a poor or a good long-term outcome. And I think that this last one is kind of interesting because adolescence is this critical period, as we all know, when what happens to you and how you develop and what you learn and all of the things that you decide to engage in really have a long-term impact in who you become and what your life turns out to be like. And in one study done by Russ Barkley, who's one of the leaders in the ADHD field, he found that adverse life events in the teenage years, things like school dropout, car crashes, drug addiction, legal system involvement, getting kicked out of school or dropping out, teen pregnancy, major injury, trauma, these are sort of the critical pieces that make or break whether an adolescent with ADHD is going to do okay in the long run or they're going to have trouble. And that kind of is an interesting piece of information paired with the fact that even typical teenagers without ADHD are often experiencing difficulties with things like impulse control and executive functioning during these years. From the neuroimaging research, there's been a finding that's been out for about 10 years showing that because the brain is maturing at unequal rates, teenagers in general have a very kind of rewards-driven behavior pattern where they don't yet have the executive functioning skills to put the brakes on and stop themselves from doing things that could have negative long-term consequences. If you couple that with having ADHD, it's almost like a double disorder in a way. These kids are really having a hard time doing what's right, making good decisions, and setting the stage for a positive transition to young adulthood. So just to get specific about the deficits that kids with ADHD are experiencing for a second. Most of our modern models of ADHD are pointing to two sets of deficits that are essentially defining the types of impairments experienced by kids with the disorder. The first one's being referred to as cool executive functioning deficits. And what we're talking about here is basically difficulties with functions such as working memory, goal pursuit, set shifting, inhibition, cognitive flexibilities, one I didn't put up here. And these are executive functions that because of abnormalities in prefrontal cortex, teens with ADHD are experiencing impairments in these areas compared to their peers who are already having troubles in these areas. The second one has more to do with your sensitivity or your response to rewards. And so these are referred to as hot deficits, reward circuitry. And this has to do with anticipatory dopamine, how much you value long-term versus short-term rewards, how much your striatum is communicating with your prefrontal cortex. And what this looks like, especially in teenagers, is difficulties with motivation and behavior regulation. Not only making decisions that are risky or non-risky, but also, do you have the ability to delay gratification? Do you have the willpower that when you're sitting there and you have to do homework, can you stop yourself from going on your phone? All of that's impaired in a person with ADHD because of these abnormalities in dopamine. So back to the persistence question, right? So if our goal is to try and have kids with ADHD end up desistant from ADHD, remitted as an adult, we really have to take a look at what has to change in the brain in order for someone to do that. And there's one study that I just think is one of the best studies, and this is done by Shaw and colleagues. And what they did is a longitudinal neuroimaging study. And if you look at this graph from their paper, we have three groups. Blue is typically developing youth from age 8 to 22. Green, let me start with red. Red is youth with ADHD who had persistent ADHD throughout this time period. And green is the group of individuals who initially had ADHD and had their symptoms remit over the course of time from age 8 to 22. And what we see is that there was strengthening of the key areas associated with those cool executive functions in these individuals who remitted. And so that's an interesting piece, because I think if we look at the full literature on ADHD, one of the things that we see is that those rewards functioning deficits are pretty intractable for folks in a lot of ways. But if we can strengthen those top-down cognitive processes that can inhibit and can kind of control those rewards processing deficits, then we might actually have a chance at being able to help folks compensate for those difficulties in their life. So honing in on these cool executive functioning deficits, strengthening that cortical control and cognitive control is really maybe a piece here that the science says could have an impact for these kids. So all that being said, then we're clinicians, right? So we have this information from research. What can we do to move kids onto this remitting trajectory? Ultimately, when we treat kids with ADHD, it's a long game, right? We're trying to help them long-term get onto this better trajectory, and that's our main goal. So how do I think about treatment? This is from Jeff Cohen's work at Stanford. I think this is a great starting place. Anytime you're seeing a case, whether you're just seeing one case clinically or you're doing a research project and you're trying to develop a treatment for a whole population, this is kind of like a really interesting just way of checking in with yourself about coming up with the right treatment. You want the right target mechanism, the right thing that you're intervening upon. And do you know what that is? And can you track it and measure it and see if it's getting better? You want to figure out the right context for delivering this treatment. You want to deliver it in a context where it's going to have uptake, where the person's going to receive the treatment, and where that population is commonly seeking care. And then you want to deliver it in a window of malleability that actually can make a difference. And this is really relevant to ADHD because we've got a lifespan disorder here. And it's not realistic to think that somebody's going to get treated for ADHD every week of their life. However, there may be key periods of that person's life where it might be particularly strategic to intervene to have the biggest impact for them. So if we're thinking about it from that chronic perspective, and we're trying to help teenagers with ADHD get on the right track, when, where, and how should we do that to have a biggest impact we can within the fact that they're not going to come and be treated every week throughout their entire adolescence. So starting with the mechanism piece. So there's already compelling evidence, right, from the neuroimaging literature, from the longitudinal pieces I showed you at the beginning, that those top-down executive functions can make a difference. And so what does this translate into in real life? Teaching people organization skills, time management, planning, goal setting, those kind of metacognitive strategies that can help you overcome impulses and organize yourself in a real world setting like school, like home where you have to do chores. All I have up here is a little table that shows that parents and teachers both rate these types of EF difficulties as the most common presenting problems that they're noticing in the kids that have ADHD in their homes and classrooms. And so this is a face valid thing to treat as well. The second piece would be motivation, right? So turning that rewards processing deficit into something that we can actually kind of tangibly talk about in a clinical setting. And so motivation is super complicated to unpack, and I'm not going to do that fully in this talk because that would be a whole other talk. But I think I just want to hit on a few pieces of this. When we talk about motivation and how rewards are impacting this, we have a few pieces that are key. Intrinsic interest in school. Kids with ADHD experience less enjoyment and less interest in the typical everyday mundane activities of school that some of us might find super fascinating to learn about history, but because of those rewards deficits, kids with ADHD don't experience that same level of engagement unless it's something that they're intrinsically very interested in, and it's something that they personally find fascinating. They have difficulties with forming goals and pursuing them. Due to inhibitory control deficits, they have difficulty with willpower, the ability to sustain attention on something that feels really aversive and boring because in the long run it helps you. They have difficulty with self-control, which means resisting the temptation to do all kinds of distracting things. And then this last one's important too. You can be motivated at a very high level, but if you don't believe that it's worth putting in the effort to pursue that long-term reward, why would you, right? So after years of finding out that you're not the best at school and you're not the best at, making friends or getting along with your family at some point, and in the teenage years, after about 10 to 12 years of data on your personal abilities, you start to realize maybe it's not worth the effort to try this hard because I'm not one of the top people or I'm not doing well anyways. So all this goes into motivation, and these are kind of things we have to keep an eye on when treating teens with ADHD. And I just like this slide, which sort of likens motivation to like an automobile. There's so many parts that have to all be working for the car to run smoothly. And if any piece of them is not working well, the whole thing is not working well. So that's really important to think about with motivation in teens. And what we talk about in that analogy is trying to put the kid in the driver's seat of that car instead of having a parent or a teacher or someone like that be in the driver's seat of the car. And that's one of our goals when we're treating these kids. So there's been work on this for decades, actually. It's been something that I luckily came on the scene when people had already figured out some of the core ways to help with these deficits. So we get to learn from those. First of all, organization skills training for ADHD has been going on for a couple decades and mostly started out in schools, where they would teach kids these strategies, and I just have a list of them up here, but there's more than this list, right? How to keep track of your homework by writing it down, how to make a time management plan for getting things done after school, systematically checking up on your book bag organization to make sure everything's in order, learning time management strategies like how to break things into small pieces, how to do certain things first or second, depending on how aversive they feel to you, active study skills, learning how to take notes in class and anywhere else where you might forget a detail if you have trouble with memory, problem-solving strategies. So all this has been around for a long time. And then I put the real classic text on this up here. If any of you've read it, it's like actually one of the best books. I read it in grad school and it taught me a lot. So Parenting Contingency Management has been around for a very long time. This book was published in the 80s. So, and it's been on since before that, but the idea that we can, in an age-appropriate way, come up with rules and consequences in the homes of a teenager that help them make good decisions in a way that honors the teen's age. So when I was in graduate school, my initial goal was to take these two strategies, organization skills training and parenting contingency management, and merge them. Because at that point, that hadn't really been done. Organization skills stuff was in schools. Parenting behavioral contracting was in clinics, but very behavioral. So like Barclay's Defiant Teens, not talking about EF skills. They're basically just talking about, conduct problems and really disruptive behaviors. So this is the building when I was in graduate school that I worked in. It's in Buffalo, New York. And as I was anticipating getting ready to do my dissertation and pick a topic, the idea was to merge these two treatments and come up with something clinic-based, useful, that could be done in 10 sessions that people could get the manual for and have something to do. Because there really wasn't anything at that point out there. None of the adolescent ADHD CBT protocols had been put out yet. This was like 2007 or something like that. So that's what we did. We brought parenting dyads into the clinic. We taught them organization skills with the parent present, and then we were helping the parent come up with a reward system for using the organization skills. It sounds super simple. I thought it was a really good idea for a dissertation. But what I really learned was that you couldn't even get these skills accessed and accepted by these families until you dealt with a bunch of implementation challenges. And these really were what was keeping people with ADHD from having a successful course of treatment in the teenage years. It wasn't the ineffectiveness of those skills. And all of you guys who have worked with teens with ADHD are probably looking at a really familiar list. But this is what came out of our first attempt to talk and work with families and figure out what they needed and how we could help them. Despite these, seemingly appropriate strategies that we'd picked out, every week the parents and kids would come back and they hadn't really used them. They hadn't really tried them out. And we would hear a lot about how, I can't check every day to see if he's done this because I don't get home from work until 8 p.m. and he gets off the bus at 3 and there's these 5 hours where no one's watching him. And, sometimes he gets home at 7 p.m. so we can't come up with a consistent homework schedule. A lot of difficulty with regulating electronics. How am I supposed to use, back then it was like watching TV and Netflix as a reward when I can't even regulate the fact that he's on it all day after school when no one's home. He needs his computer to do his homework. I can't take it away from him. Kids who would come in and tell you everything was going fine until you saw their report card and then you realize it really wasn't going fine. So that's hard to intervene when there's a disconnect between what one person's telling you is going on and what's actually going on. And then challenges and barriers that we were experiencing with the parents. So folks feeling really impatient and not satisfied with the fact that in a chronic disorder, sometimes change is slow and you're not going to see immediate results. And people wanting to give up when they don't see those immediate results. It's parents who have a lot of stressors and who don't have a good outlet for discussing those stressors and getting support for them and want to just use the therapy time to complain about what was going on and to try to, solve the problem of the day instead of practicing and working on skills long term. A disconnect between what families came in saying was the problem and what sometimes as you got to know them, you realize was the true issue causing the impairments. And a very strong held belief that is specific to adolescence and adulthood and hasn't quite crept in yet when you're working with younger children, which is that behavioral strategies don't work because I've tried them a million times and they don't last forever. And they're right, they don't last forever. And so it is hard to overcome that and suggest things that have a behavioral element when people have learned from personal experience that these are not long-lasting solutions. But yet we know they're valuable anyways, in certain ways. And there's actually one piece of this that I really want to spend an extra minute on. So a paper that my team did wanted to take a deeper dive into the parenting patterns that were causing and interfering with the success of the kids. As we started to notice them clinically, we started collecting data on the strategies that parents of teens with ADHD were using in order to help, manage or address the difficulties that their kids were having. So we did a latent class analysis where we basically gave a questionnaire that had a lot of questions about your parental academic involvement strategies to 299 parents who we were seeing clinically for one reason or another or in a research study. And this is a graph from the study, which you'll see there's 4 groups that I'll jump into in a little bit more detail in a second. So you've got one group that follows this orange line. This first set of strategies here are a bunch of assistance strategies. So they're high on assistance, and they're actually also the highest on using behavioral strategies as well. They are doing everything they can think of to help, good or bad. You've got this other 2 groups in the middle who diverge here. So here they're doing similar levels, moderate levels of helping and assisting. And then here you've got the blue group who uses a high amount of behavioral strategies. And then you've got the gray group who uses a low amount of behavioral strategies. So gray is just helping, not trying anything preemptive, whereas blue is trying preemptive things. And then you have the yellow group who essentially is not doing much at all. So this is interesting, and we can kind of actually paint the picture of these folks and what's going on. So this is our adaptive group, and I'm not going to present all the predictors and outcomes associated with these groups today, but just suffice it to say that this is the group that's has the lowest associations with parental psychopathology and teen severity and other negative predictors. This is the moderate group. You know, it's that balance of the teenage years. They're helping, but they're not helping too much. They know how to use contingency management as needed. And these are the folks who have the highest level of autonomy support that they're offering the kids. So ultimately, there's only 20% of them, but this is the group who seems to have gotten the hang of a good balance for parenting these kids. And this is a goal for treatment, is to move more parents into this adaptive group. We have these other groups that are a little bit more problematic. So, you know, we saw high levels of anxiety in the parents who were in that high try everything group. And this group of folks has a very high level of monitoring, a very high level of homework help. They're organizing everything for the kids instead of letting the kids do it. They're frequently contacting the teachers multiple times a week. And these are teenagers, right? Issuing a lot of consequences, but without a lot of autonomy support. So they remind us of the helicopter parents that we hear about all the time. But we have to have compassion for these folks, right? Because they're not doing this because they're, bad parents, right? People get caught in this trap, right? Where it feels like, my goodness, my child is going to tank and fail out of school if I don't sit next to him and make sure he does everything every day. And over time, parents get reinforced that when I do this, my kids get higher grades, so I got to keep doing this. And people get very stuck in this trap, and sometimes it feels like the only way to prevent a catastrophe. The homework assistance group is that group that's helping all the time but using no contingency management strategies whatsoever. So they're basically doing a lot of sitting down and helping, and they were the group most likely to admit to doing entire assignments for the teen. So I think they're kind of reacting to the teen's problems by, we've done some follow-up work on this actually, which I'm not presenting, but they seem like folks who could be basically trying to get homework done quick, get people to bed on time, and so it's easier to just kind of do things for the kid than to have the kid do it themselves. And then finally, and same deal, we have to have compassion for the situation, because sometimes people feel like the only way to get everyone to bed and to get this night over with is to just kind of help and do some of this for and with the kid, and so that's happening for some folks. And then finally, we have this uninvolved group, who's actually the biggest group, 40%, and this is associated with having older teenagers. So the data's not up here, but that was one of our findings. And these folks are not using any rules or consequences. They have very low monitoring. They're not helping either. They're just sort of letting the situation go. And we imagine with the older teenagers, since that is associated, that, people we're going to try to look at this longitudinally, but we hypothesize that people may in middle school help a lot, try to keep them through, and they kind of just burn out of that strategy eventually. And by the time they're in high school, they kind of just have given up. So that's a hypothesis we have. And one piece of that may be that, checking out may actually just feel like the best way to keep the peace for certain families, instead of being on top of them and getting a lot of arguing and fighting back. And we do see that there's an association with higher levels of ODD and this pattern as well. So just some clues. But all of this sort of takes us back to what it's really like to be the parent of a teen with ADHD. And I think, based on my work with this population, I think that the key word for this life is dilemma. You're just faced with dilemmas every day, and none of these dilemmas have a clear answer. So what are some of these dilemmas? How much do I help versus step back? Should I let them experience the natural consequences of their actions, even if it means serious outcomes like dropout or arrest? Should I stick to my rules, even if it creates a lot of conflict and arguments at home? What battles are worth picking? How late should I let her stay up doing homework? Are grades more important than sleep? Should I put him in gifted because he's bright, even if he has trouble managing the work? There is no clear answer to any of these questions. And as clinicians, we don't have them either. So this becomes challenging when, you take on a case and you think you're just trying to help with organization skills, and then you open up all these cans of worms, and it's like a lot for both the family and for the clinician to try to sort through. And these are the real things people want to talk about when they come into therapy. They're not saying, oh, can you just teach them an organization habit and we'll be good. This is really what you have to manage. So after I learned all that, we tried again. And so STAND is the name of the treatment I'm going to share a little bit about with you all. And what we ended up coming up with for my dissertation, which was our first time testing this, was this idea that we would do a 10 to 12 week clinical treatment, which is the original idea. But now we're going to really focus on engagement instead of just putting all the focus on the skills teaching. We're still going to teach the skills, but we're going to spend a lot of time with the engagement issues surrounding the skills. And we use a lot of motivational interviewing to be able to achieve that goal. So let me just show you real quick what the organization, time management, and planning skills training looks like. So just some sample materials, right? So homework, time management sheets. We might do this with kids where they kind of figure out how much time they need to work on things, what order they need to work on them, setting kind of strategic process for doing their homework, teaching them skills like how to break things down into smaller and smaller steps till it's easier to get started. Organization, checklists where you, with your parent once a week, might make sure that everything's where it should be in your book bag and kind of keep a consistent routine with that. This is just some of a collection of strategies that we teach. Parenting, contracting, just for those folks who haven't done this as much, some of the key pieces of this are the parent and teen come together as equals to discuss a shared problem. They are both have to come in with the mindset that they may have to compromise to get a shared agreement or goal. The compromise is the kid may have to agree to some more contingent rules, some limits on their freedom at home. The parent might have to be willing to extend greater freedoms to the teen if the teen holds up their end of the bargain. And in our version of contracting, in light of these interfering parenting behaviors we've seen, we added a piece where the parent has to specify things they promise to refrain from doing, which could be giving tons of reminders or doing things from the kid for the kid so that we can make sure we're preserving autonomy and also teaching the teen to do things on their own and not just be reminded to do them all the time. Just some sample material. So we have an intro to contracting, which is teaching some communication skills so that when we try to contract, it's not just arguing all the time. So this could be active listening and I statements, really classic, parent-teen communication skills. And then this is just what a template of a contract looks like for folks who haven't seen it. Really detailed stuff about when and where homework's going to be done, for example, and what the rules are and how you're going to create a distraction-free environment. Some contingency management attached to it, and people sign it at the end. Okay. So I want to really spend some time now on the engagement strategies because that's what's kind of unique and novel about what we've been up to. There's a strong motivational interviewing community in Seattle, so a lot of you probably know a lot about MI. But this was the first thing we did, was we said, what is out there that improves engagement, that's evidence-based, that we can try to bring into our treatment? And 10 years ago when we were coming up with this, MI was an obvious choice. So I could talk for a day about how we're using MI and STAND, but just one brief slide. So MI talks about both the spirit with which you work with folks and the strategies you use to increase their readiness for change. And with respect to the spirit, it's a nice match for what we're trying to promote in teens with ADHD anyways. Honoring autonomy and building autonomy for people to make choices that feel right to them. Building self-efficacy, something that's lacking in many teens with ADHD. Expressing empathy for folks who probably don't get a lot of empathy expressed towards them. And surrendering the expert role to collaborate with the family members as equals, which is important because when you're working with teens who are oppositional, a really good strategy is to not seem like you're an authority figure and to just come as somebody who's there to help them figure out what they want to achieve in their own life. With respect to the strategy of increasing readiness for change, the MI perspective talks a lot about what our clients say and the speech that they use, and analyzing that to find statements and utterances that indicate an interest in changing, and to then selectively reinforce and give attention to those statements so that the conversation becomes focused on those statements, and those statements feel stronger to the person. And so that ultimately what feels most relevant to them when they're making decisions is these change-related values, and these values that make them feel more like it's the right thing to do, to make a certain change, to promote what they ultimately want in their own life. I'm going to show you a few examples of specific things we do to increase engagement. So this is very MI consistent, working on and spending entire session on strengthening values before you teach a single skill. So instead of jumping right into skills, we're talking about getting people to check in with themselves and kind of remember what's important in their own life, both the parent and the teen, so that they can then be in a position to feel connected with the potential strategies that we're going to introduce. So this is just an example. You can see all over here. I don't know how easy it is to read, but there's a bunch of different potential values for a teen. So things like, getting to spend time with my family, driving privileges, getting good grades, being popular, etc. What do you care about? And then you get folks to talk a little bit about what on here is important to them, and that gives you themes and treatment too that you can link the strategies to. Taking a strength-based approach. So that's so much with ADHD, we focus just on deficits. But here we're really trying to harness strengths in order for folks to use those strengths to be their best version of their self. And that's really important because ADHD, the deficits will always be there. We're just going to learn how to manage them better. And the best way to manage them better is to use those strengths to manage them, and to find settings where your strengths are valued and you feel good about yourself, and you can potentially be successful in spite of the difficulties. So we're very affirmative with them, which also builds self-efficacy. And then from the get-go, kind of this message that change takes time, especially if someone has ADHD, because it's a chronic disorder that's notoriously impacting motivation in the areas that help us change. So from a perspective of a clinician, we have to also acknowledge that perspective as well. There are psychological conditions that are necessary for people to make big changes in their life. We can all think about our own lives and realize that. You can't just kind of go in and teach anyone a skill and they're all going to uptake it immediately. So not only do you have to want to change and believe that you have the ability to change, you have to have an emotional connection with the reasons that you want to change, so that you'll put down all those downsides that are popping up in your head and and put in the effort to do hard things anyways. And so working with folks to develop that sense of urgency while we're in our communication style. And this is just from the MI literature. But, this is a continuum that a person might walk along from not wanting any change to eventually making a big change. And like I said, there's a piece that's desire. You've got to want it. You've got to feel you can do it. It's got to feel important right now. And then you've got to kind of internally in your head commit to it before you'll even do it. Most of our evidence-based, skills-based treatments, they start right here with let's do it. Let's make a plan. Time to learn a skill. But if we don't acknowledge that this has to happen psychologically for a person before they're ready to do these things, then we've missed a really big opportunity to make those skills stick. So with MI, we're acknowledging that process has to happen first, and we're putting time into it before we go and teach any skills. And that's what we're trying to do in STAND. And ambivalence is where most of these folks are falling. Most of the time, no one walks into treatment, except for maybe the teen whose parent dragged them there, that wants absolutely no change, right? You can usually find some change that somebody wants, even if the ambivalence of not being sure if they should actually do this thing. For parents, you can imagine that's backing off and letting them do their homework on their own, even though they're probably not going to get very good grades at first. For kids, it might be agreeing to let my mother hold on to my cell phone every day after school, even though I want to talk to my friends all the time because I realize that I need to get better grades in school. So helping people work through those types of things before we go into the plans puts them psychologically in the right place. Homework is a big part of evidence-based practices. We call it practice because if you're coming in for homework problems and then I assign you homework, that's probably not the best way to start off on the right foot with it. So it is therapy homework, but we're calling it practice. And we've spent a lot of time trying to figure out, how do you actually design these practice activities in ways that will actually promote people doing them? Because that's really, kind of the sticking point for a lot of families. So, yes, like every evidence-based practice, we know that homework promotes skill generalization. Everyone knows that. But here's how we're doing things a little differently. We say up front that you're free to tell me you don't want to do this. So we only want you to agree to this if you feel like you actually want to. And then if people don't want to, which is very rare, working through that with motivational interviewing. We let people design and come up with their own practice activities that they think will be helpful for them, rather than giving them a worksheet and telling them what they need to do. We start with really easy things that pretty much everyone can remember to do, and we slowly, gradually advance to more complicated assignments over time. That's a behavioral principle, so it kind of fits with our overall approach. And then whenever we're starting to assign something, we spend 5 minutes talking about their reasons for feeling like this is valuable and how they would do it, to actually not just have it be this quick thing that's handed to them at the end of the session, but this like kind of big part of what's happening. I'm going to come back to this and circle back in a minute. This is a piece of it. Personal goal setting. So parents are setting goals for their parenting, not for the teen. And teens are setting goals for themselves that they want, not for what the parent wants for them. So everyone's coming up with genuine goals that have to do with themselves and not the other person. And that gives the therapist an opportunity to make that a theme of treatment and consistently connect the values to the goals, to the target behaviors, to the strategies and skills that we're learning. It also is a great strategy to model for the teens about how you can use goals to keep yourself on track in everyday life when you have trouble with motivation. Using a menu-based approach. So ADHD is very heterogeneous, right? So everyone's struggling with different things and they're living in different contexts. And so this can't possibly look the same for everyone. So we have a menu-based approach where we encourage families to pick maybe 2 skills at first that feel like they would be the most helpful. We're not trying to throw the kitchen sink at them and try to teach them everything and have it kind of their eyes glaze over. We're just trying to get really good at a couple key habits and linking their choices off the menu to their goals and their values. So back to the home practice for a second. We've been working really hard on trying to implement something that we're calling imaginal practice, and it's like an imaginal exposure that you would do for an anxiety treatment. Before they implement a contract, a plan for at home, we spend like 10 minutes closing our eyes if you want to and thinking this through and coming up with all these scenarios that possibly could derail the plans and talking to the families about, okay, what will you do if this happens? What will you do if that happens? Because we know that it's constantly going to be threatened, every plan, with a logistical barrier. We come in all the time, say, how did it go last week? And they say, oh, well, we couldn't do it because we had our aunt staying with us this week. So, we have to think about those things when we're assigning the home assignments. What will you do if your aunt comes to visit this week? How are you going to handle that and make sure this still gets done? And so really spending the time on that, walking through it imaginally, then the family feels empowered that they're ready to handle all these different things that could happen. And it becomes and atypical days become part of the plan, not the reason why you can't do it, right? So it becomes a challenge to just be really good at overcoming all the possible things that could come up. And spending minutes on this in your therapy session just reinforces the centrality of it to the overall piece of what we're doing. And we're pairing this with something that's from the social psychology literature, implementation intentions. So the idea here being simple if-then plans, right? So if he leaves his cell phone at school and I suddenly don't have a consequence to take away if he doesn't do his homework, then we're going to do X to solve that, right? And it's just these simple if-then plans. If I didn't write down my homework and so I don't know what it is, then I'm going to call my neighbor. Those types of things. So people kind of are ready for everything that life will throw at them. So I'm going to show you guys a video and then I'm going to talk about the research that we've done on this approach. So with respect to the video, it's just like a 6-minute clip. What you're going to be watching is a family that is a real family that volunteered to work with me a little bit and have some of what we did videoed. And you're just going to see a really easy activity where we're spending time before we even start anything in treatment, just talking about their motivation for starting therapy and just putting in those minutes and doing a little motivational interviewing to get them in the right mindset before we even teach a skill. So 6th grader, 12 years old, inattentive type ADHD, mostly on medication, and coming in for a lot of organization skills and motivation problems that were preventing him from, he's at risk for failing out of his honors gifted program because he's got mostly D's and F's. So he's coming in with mom, and we'll see a little bit about what they talk about in terms of their motivation to possibly learn some new skills as a family. So we could start out by looking at the letters that you guys wrote, and you pulled those out right away.
Yes.
So I think it's up to you, Matthew, if you want to start by showing us what's in your letter or asking mom to start.
Mom, you start. Okay. So I wrote, just as with many other things in your life, things will get
Money?
easier.
You say money?
No. Why are you interrupting me?
Okay.
Just as with many other things in your life, things will get easier. There is so much hope. Parenting is still a challenge, but things are better. You must put consistency and routine into your efforts. This is a must for Matthew. You must tone down your approach when he doesn't perform well with school and responsibilities. Take some time for yourself. All of what is happening for you is not going to be the end of the world. Just do your best and you will get through it. Have patience.
I like a lot of that.
Do one of those 3 years count as this year?
Yeah, I could.
Oh.
So, listening to that, it seems like you kind of have a lot of confidence and hope that that you can do this and you can meet some of those goals that you set for yourself.
I hope so, and a lot of it also has to do that I've already gone through this once before, and,
Yeah.
and things did turn around for us, so I'm really hopeful that things will be similar.
You saw that your whole family was successful once with your older son,
Yeah.
and so you kind of feel that that sense that it's going to be okay again.
Yeah.
And one of the things you mentioned in there was to make sure you took some time for yourself too. I want to hear a little bit about that, Greg.
Just for me, I mean, I take on a lot of the issues in the family. My husband's a lot more laid back, so he's kind of not like in the middle of everything like I am. And I think it's not good for me to not just have time for myself. And really right now, like the only time really that I have by myself is just driving to and from work and, you know, stuff like that. But I think it's important just for my own personal being to start looking into doing that and being, I think that'll make a benefit to other situations if I'm not already, like, I don't know what the right word is, like, you know, too much into other stuff, so I'm already like, you know, at level 9 when I could be, you know, at level 2.
So if you took space for yourself and you kind of took care of your own well-being, that would translate into, as a parent, you know, just sort of reflecting that well-being with the kids, and and that could benefit them in certain ways.
Sure.
And that's sort of what you're seeing there.
Yeah.
And another part that you were talking about was just that desire to kind of like focus on consistency.
Yeah.
That was in there too.
Yeah, right now I know, like, we do a lot of work with Matt and my other son, but there is an inconsistency there, and I don't think that benefits him at all, because it all depends on my work schedule. We talked about this a little bit before. So, you know, and usually like the first 2 weeks of the month are not good for me at my job, and I'm usually staying a little later, and I run like on a fiscal calendar, so quarterly, yearly, you know, and my year end is coming up now, so it's going to be nuts once April 1st hits. But trying to, at least if both me and my husband are on the same page with everything, that he can pick up the slack and just maintain a consistency where if somebody has to check his homework every day, if I'm not there, my husband will do it, or, you know,
You're
just to
right.
make sure that he's doing the same thing every day, at least.
So that you're able to kind of have everyone work together to create a consistency for Matthew, even if it's not the same person every day checking up on things or helping him with something, that there's always someone there to kind of to work together and create that for Matthew. So you sort of see one of the things that you want to focus on is taking steps towards figuring out how to do that.
Right.
Okay, so basically, just to sort of summarize, it was sort of like you're feeling hopeful about the future, and you see that the major steps towards getting to where you want to be are not only taking care of yourself and making sure you keep yourself in a good place, but also kind of engaging everyone in the family to focus on creating consistency for Matthew. That when that consistency is in place, you think he'll do his best.
Yeah.
Okay, that's a lot of really nice thoughts. Matthew, do you want to tell us what you work on?
Sure. Hello, President Salt. This is you from 3 years in the future. I'm writing to you because I'm going to tell you how to get organized and do well in school, just like me. First thing is to get organized. Make sure you have everything you need for school in your book bag. Also, you need sharpened pencils for the work. These things have helped me stay organized for school every school day. Secondly, you need to study in order to do good on a test. Also, you have to take school more serious. That's how I reached my education goals. Take this advice and it will help you.
How'd you choose what to write there?
I just thought of it since what we've been talking about these past days. I've just been making up like a summary of what we have been talking about, and I just wrote it down.
So some of those things felt kind of important to you.
Yes.
What did you think was the most important thing that you need to do?
Taking school more seriously.
What does that mean to you?
Like I had to like stop slacking in school. Rarely, like I rarely do it, but even if I do it, I do need to stop it so I can take it more seriously and pay attention more.
So you want to kind of be able to notice when you're drifting away from doing your work and bring yourself back, something like that.
Because sometimes my friends will talk to me and then I'll get distracted. And then I'm like, I need to work on this. Can you stop for a minute?
So being able to kind of notice again like that you're being distracted and try to do something about it is something you'd like to do. Why is it important to you that you do better in school?
So I can get a better life and a good job and a good college. So I don't have a horrible life.
You're looking forward into the future and you kind of want to see yourself happy and you think that school's like an important link to that.
Yes.
And you're seeing that organization and getting your homework going now is kind of the key for you.
Yeah.
So looking forward, we're going to start working on some of that stuff even today. How ready are you feeling to kind of try some new things out?
I'm feeling good.
Point being, whereas with Mom in there, we're spending a lot of time actually trying to like use motivational interviewing to create some internal change process for her and think like I really need to do this. I really need to make some differences to my parenting. With Matthew, we're really just using it to try to get him to be open to learning some new things and being willing to try out these skills and to take some of the limitations that are going to come forward in that contract. So the MI is being used with both family members, but in different ways. So, I'm just going to spend the last bit here sharing with you the research that we've done and what we're doing now. So, 2009 to 2012 was sort of when we were doing pilot work on this. So we had a few different smaller grants from different foundations that helped us with this. So this was my dissertation, clinical trial with 36 kids in it, 18 assigned to stand and 18 who were just getting whatever treatment they were normally getting in their community. We've also done a pilot where we tried it out as a group, and we did one where we did it over video conferencing. So some of this was our kind of smaller, earlier work. But luckily in 2012, I think, 2012, I was co-PI on a grant with Bill Pelham to look at a larger RCT of this treatment, and it was 128 kids. We wrapped this up in 2015. Just like a brief little overview. This is our main efficacy trial. So we had 128 kids who are 11 to 15. They were from schools all over the county in Miami where we were working. They all had ADHD, and we are always testing this intervention out at a little bit of a challenging bar, which is kids who are in regular education settings or gifted, but the idea is that they're not in a self-contained classroom where they're already getting a lot of supported school. We want the typical middle and high school kid who's in that kind of chaotic environment at school to try to see if we can help them overcome that typical teen environment. They're allowed to use medication. They're matched on medication status in this trial. So we assess them at baseline, post-treatment, and 6 months follow-up after they ended treatment. They got 10 weekly sessions. The therapists were pretty much all trainees. And this is what the sample looked like. So middle-class kids, average IQs, typical profiles of comorbidity, on average about 13 years old, and mostly Hispanic or African American. Measuring outcomes for teens with ADHD is complicated because there's no perfect outcome measure. So we get information from parents, from teens, from teachers, and try to take some direct observations and use official records and put it all together to try to tell a story of what's going on. So what were our results in this study? And I showed the reference if you want to read more about it, but just the kind of brief take home. So we had good fidelity. People were using MI with integrity. People, the middle-class families in our university trial mostly completed treatment, did 8 sessions on average, generally liked it, were satisfied. And we saw nice medium to large effect sizes on the things we cared about: ADHD symptoms, parent strategy use, kids' organization skills, parent stress level. Some things didn't maintain 6 months later, but we still had effects. So observations of the kids writing down their homework, their behavior at home after school, and other parenting skills, the use of contracts long term. And there were some effects that were non-significant. For grades and book bag organizations, we had around 0.3 effects, and that we weren't powered to detect that. And then a couple of the things, the parent-teen conflict according to the adolescent, the ADHD symptoms according to the teacher, we did not see change over time. So there's a couple thoughts about that. If I want to give myself credit, I'll say, well, let me show you this possible explanation, which is that, and this is true to some extent, there's this is a home-based intervention. So there's this transfer that happens behind the scenes of the baton often from the parent driving the show. You saw about 40% of the samples using this like parent assistance strategy to keep their kids afloat when we first meet them. So for a bunch of those folks, this is a true quote from treatment. He's still getting B's, but now it's his B, not my B. So that's worth mentioning to you all. However, we also have sort of this like challenge in the field of teen ADHD where we're trying to document that there's transfer of this to school, but the teachers teach 100 kids and see them for an hour a day and don't necessarily know them that well to begin with. And so we don't always, no one in teen ADHD treatment studies is really getting a lot of teacher-rated effects. And we have small impact on GPA. So we're still working out this issue and trying to figure out how much of it's methods and how much of it is us needing to work harder to find ways to impact school as well as home. People always ask me, can you do this as a group? Because that's really practical. So yes, we've done a study that was just published this year in the blue one, Journal of Clinical Child and Adolescent Psychology. And we're looking at whether or not the group holds up like individual with the parent and the teen. Now, the thing is, we don't do MI in the group, although there's MI features in the group. Really, we're relying on a different process. We're relying on what typical group treatments rely on, which is shared experiences with others, learning ideas from families who've been through the same thing, building self-efficacy by seeing other parents who try things out and are successful, and the same thing for the teen. We have a parent group and a teen group. They meet concurrently. So we did a 123 kid study founded by the Klingenstein Foundation. Same content, same skills taught, right? Just a different way of implementing them. So our results were overall, they showed about the same amount of effectiveness. So since group is cheaper, that could be more cost effective. But if there was a complicated clinical profile, the individual was more effective. So this was true for parental ADHD symptoms, parental depression, and parent-teen conflict. So I feel like these results are logical, right? For like your pretty classic ADHD kids and families, the group is gonna work for a lot of them. But when folks need a little bit more one-on-one to be treated appropriately, the individual works better. So what are we doing now? We just wrapped up a R01 of doing stand in community mental health agencies, and we're kind of working on getting those results. They're under review right now, so we're working through presenting them as good as they can be presented with our reviewers. So hopefully in the future I can present to you a little bit on that. We are currently analyzing about 1,000 audio tapes from therapy in these different trials to try to understand things that the therapists can do that can increase the likelihood that people will do their therapy homework and have a better outcome. So it's kind of neat work where we're doing really sequential analysis about what one person says and one person says next, and looking at those micro conversational tools people can use. We're doing an integrative data analysis where we're combining 4 trials, including 2 that I presented on today, to look at complex mediator and moderator interactions about which kids struggle and do well in treatment and what are interfering and facilitating factors to help kids have good outcomes. And we're doing something novel now, which I'm really excited about, which is task shifting intervention delivery to peers in schools. So same skills, same strategies, but can we train 11th and 12th grade honor students to do some of this stuff with the early high schoolers who are struggling at that transition? So we just wrapped up an IES grant on that and trying to get another one. So that's my talk. So people to acknowledge all of these hundreds of families that helped us with this, that gave feedback, that led us into their lives. All the therapists who spent all their hard work kind of not only delivering the treatment, but telling us what wasn't working and what we needed to do better with. Most of this, the bulk of this funding was from NIMH, so acknowledging them, and then also the foundations that also gave us funding. CHAD has been involved in this. Some of the early people who helped conceptualize this treatment who are really important, and I've learned so much from being a part of the Mint and all the lessons from that too really were inspired in this treatment. So thank you.
So terrific presentation and
Thanks.
terrific work. I am wondering, I have a very simple question. I'm wondering if you have a cutoff that you use in terms of the level of ODD, because I feel like there's that complicated line as ODD moves towards CD, and who can we include and who's better off served in a different way?
So we've never excluded based on ODD or conduct disorder. I don't think we typically get a lot of conduct disordered kids referred. Like I've usually had about 5% in my samples, and I think that's because they're screening themselves out. Like if that's going on, then they're typically seeking a higher level of treatment than what we're offering. ODD is a moderator of how much people do their homework, and it's a moderator, as you kind of saw hinted at with the parenting conflict, of treatment response to some degree. And I think that a lot of the times we can address the ODD by adapting the treatment within the context of standstill and being true to the stand model by choosing target behaviors that are related to that, because it does still respond to behavioral treatment approaches. But I think it can be an interfering factor in treatment if it's really severe. Yeah.
I think this is okay. Thank you so much. This is really very exciting work and so thoughtful in terms of how this program unfolds. I wondered if you could maybe say a little bit more about this, the waning effects of the behavioral interventions, and how you think about how you talk to families about that, and also how you think about the role that those play in sort of longitudinally.
I have like a personal view on contingency management that I think is also inspired by the social psychology literature and the motivation literature, which I've tried to really study. I like to think of it as like a stopgap measure for when things get really rough, because it is effective at changing behavior. But one of the downsides of consistently using like a adult implemented rewards and consequence approach, especially with a teenager, is that you're potentially preventing people from learning from natural consequences, and also from for the development of intrinsic motivation, which we know from like the social psychology research really only develops when people are given autonomy and allowed to be in situations that they're personally competent in, and feeling control over their own situation. So it is this balance. So I think the way we talk about it with families is that they have a personal choice to make about whether right now feels like a crisis enough, or like important enough to go to a behavioral approach, versus you want to let this be one of those times where we're going to kind of let them learn from experience, and you're going to personally accept that may come at a consequence to other things, like your own control over their behavior or their grades or something like that. So it's kind of a give and take between using behavioral strategies as needed and then kind of letting them live a little too in the meantime. So that's my take.
I have a couple of questions which build off with what both Elizabeth asked and Nat did. And many of us have seen these kids for long, long periods of time. I have a college population of students that I still follow. And one question, and just in terms of how you construct this in the context of it clearly being a neurodevelopmental condition, you have some treatment effects. They're not huge, but they're present at the end of the study period, and then some falling off, but a little bit of maintenance at 6 months. And so my question about that one is, how do you think about this longitudinally? Are you thinking about booster sessions built into the longitudinal texture or fabric of care, or what do you tell families in terms of how to think about managing this or help-seeking behavior, not just over months, but years or decades even?
Yeah.
So that's one question. Then I have a second one. I'll go with that.
Okay, yeah, so that's a good question. When we schedule booster sessions for people and say, in a month, we're going to hold a booster session, everyone come back. Or when we say, give us a call if things start to get worse, there's not a lot of uptake. In our pilot work, we tried that. We said we're going to have a booster session once a month because that seems like what's being recommended, but people didn't really want to come. So that's a bigger issue. I think, what we should be trying to do as a next step is training people to understand that that the way they should think about their ADHD is that there's going to be like flare-ups over time, and to acknowledge when those flare-ups are happening, to be able to recognize that and to seek help at that time. But I think a greater call for the field is, how do we create a developmental treatment infrastructure where you can be 19 and really struggling with the transition to college and know where to go? Because it's really hard when you don't live in the hometown you grew up in, and you had a therapist as a kid, but they mostly treat children, and who do I call now? And there's not really a good advertised ADHD service at my college. So I think that's a bigger infrastructure question, because we do know what acutely effective treatments are: CBT, medication, behavioral treatments. So it's more about how do we help people access them when they need them. And I think about developmental transitions as key points where we should be, checking in with folks. And, how do we create an infrastructure where, just like anyone with a chronic disorder, diabetes or anything that's health related, there are these sort of check-in points with folks where professionals can also help them assess whether or not there's a flare-up going on right now and something needs to be done. So there's some system questions that I think our field is starting to have time to look at now that we've figured out what our effective treatments are. It's a good question.
And the second question, you may have said it, but if you did, I missed it. And we all know and love the helicopter parents, and we know we don't necessarily love the oppositional kids that are couch potatoes, and they're sort of part and parcel of who we take care of. And did you break that out in terms of response, in terms of what those kids look like, what these families look like, in terms of how, if at all, receptive each of those groups was to the treatment paradigms that you were employing?
Yeah, I did a presentation on that once, and we did look at the moderating effects of that. And I never published that because it just I didn't have time. But and I don't fully remember all the details of the findings either, but there were moderating effects of that. And I think it was mostly on the parental variables that you saw the effects, not the kid effects, if I'm remembering correctly. And the idea is that there's different pathways to getting the same symptom reduction in the kids. So for the parents who were not doing much, what we saw was they had increases in strategy use. And for the parents who were doing too much, they had decreases in strategy use from point A to point B. We're trying to bring everyone to the middle, and ultimately the data suggested that everyone's symptoms were getting better through these different paths of parenting changes, which were different from each other. So if anyone wants to see those graphs, I have them in a PowerPoint somewhere, but I never published that. So yeah, it's a good question.
So yeah, it was very interesting. So a follow-up question on that is that, do you think it's possible then to tailor the parenting interventions? I mean, you've got 4 styles of kid-parent interactions. It seems like there may be 4 different intervention styles for that. And second, it does seem your first question was, how do you do something for the persisters and predict the persisters over those that aren't going to persist? But the model and the whole notion of having research trials and having people enroll and consent and come to treatment, you're already biasing towards those that are not going to persist. And so how do you take these to the kids, to the conduct disorder kids, to the kids that were getting a B would be, a triumph no matter who did the work?
Yeah, I think that, this is a treatment for people who haven't escalated to that yet. And there's another treatment for ADHD for people who have escalated to that. And it's all about the clinicians out there being aware of the different options they have and learning how to tailor them appropriately to their family's profile. So I always say I don't purport that this is a panacea for ADHD in teens, because it only helps with a subset of the problems. For the question about the persisters versus desisters, though, I think we need to be in more community mental health settings. We need to be in schools. We need to, I have a paper that we haven't submitted yet, but out of all of in this integrative data analysis, out of all of the clinical variables and socioeconomic variables and kid profiles and parenting profiles that you could throw into a model with over 800 kids, the number one thing that was predicting bad outcomes across a year in treatment or not in treatment was like these psychosocial risk indexes, kids who have a lot of adversity. So I think in a really important direction, because that directly translates into who's going to be a persister or not, is figuring out how to get into these contexts where those kids need help and how to tailor our ADHD treatments for these high-risk families, because in my community mental health trial, which is mostly those high-risk families, we're barely getting any meaningful effects because the kids are just so much harder to work with. So that's a call as well for what to do next, and that might take a lifetime. So we need people to help with that. If anyone wants to collaborate, yeah.
That was actually a nice segue into my question. Great talk, by the way. Related to moving into schools and community mental health, and knowing that so often when we create our effective interventions, one of our implicit or explicit goals is large-scale adoption and delivery in all sorts of accessible settings. I wonder if through some of your work in CMH or through schools, you've developed any understanding of which of the kind of many skills and techniques that are embedded in STAND might get you the most bang for your buck.
Yeah.
And knowing that the less change required within a system, the more implementation can occur.
Yeah.
Do you have any thoughts about ways to kind of make it that much more scalable and to achieve that goal you were just talking about?
Yeah, that's a really interesting question. I think that's what we're trying to figure out right now. So we're going back to our community mental health therapists and having some focus groups with them after the effectiveness trial to kind of figure out what their perspectives are. One of the things that we identified in that trial was a major barrier was just the supervision structure of community mental health. So they, in the agencies we are working on, and this is consistent with the literature, they're getting like 30 minutes of case discussion a week. And that's hard when you're trying to make sure people are doing MI correctly and want to review audio tapes with them, and then also have these complicated families that you're trying to problem solve individual treatment planning with. And so I think there's some systemic things that probably we need to fix as a piece of that. And then in terms of like trying to tease it apart, on average, our families were getting 12 to 13 sessions in 6 months in community mental health, but only covering about half the content that they were getting through in 10 sessions here. So what we found is our later session fidelity was basically 20% because people weren't even getting to that content yet. So that is an interesting question, I think, that gets raised about there were smaller effects and they weren't even getting all the treatment. So can we pick out a piece of it that feels more manageable and can at least make it, from even an MI perspective, like even making a small step with a person who's facing all these adversities may be really meaningful to them. So I think that's where we're headed. Yeah.
Is it working? Oh, there you go. Thank you for the talk. I was really excited to hear more about this. I picked up the STAND manual at some point a couple of years ago in my training and read through it and was really excited about it. So really excited to hear a little bit more today. One of the questions that I had came up as going through the talk is it sounded like this was really a treatment that you designed to address the needs of teens with ADHD, and also recognizing that there are teens without ADHD who also struggle with things like executive functioning and motivational challenge and parenting issues and parent-child conflict. I'm curious if you've thought about adapting or like using this in non-ADHD populations, or how you feel like that would or could apply to kids with other diagnoses that might be experiencing similar challenges.
Yeah, I would say even though we haven't done a research study on it, I don't think it hurts any clinician to go for it and do their own kind of like, empirical evaluation of whether it's working or not, by assessing the outcomes of the kids. I think that's the idea, is that people should be matched to treatments based on functional problems, not necessarily diagnostic categories. So even though the NIH wants us to make sure everyone has ADHD in order to put them in the trial, that doesn't mean that we thought that was the only people this was for. In our IES peer-delivered trial, we're letting in any kids who have elevated, difficulties with organization, time management, planning, and those types of symptoms, and we're seeing good effects. Probably we're seeing bigger effects there because we have some less severe kids in the group as well, and they're easier to help change. So I would agree with that. Yeah.
Well, thank you,
Thank you.
Maggie. We can see into the future and know that the children in our region, the trainees in our institution, and scientists are going to really benefit from your being here. Thank you for the wonderful talk today.
Thank you. Thanks for everyone being here.